Today is December 17th. It's 12:30 on a Thursday. I have Dr. Sachin Vaid joining me. My name is Kemal Erkan. I'm the chairman of American Surgery Center as well as United Medical ACO. Today we have Dr. Vaid with us. So we have done so many bariatric events, but this is our first live event on the colonoscopy, at least with me as the first one. So Dr. Vaid, if you can please introduce yourself and then we'll start from that point.
Good afternoon, everyone. Hi, Kemal. I am Sachin Vaid. I am a colorectal surgeon, and I've been with the CHRIAS practice for the last 5 years. And we operate out of the hospitals, Christiana Hospital, St. Francis Hospitals, and also at our own American Surgery Center, which we've been doing for the last 5 years.
So thank you, Dr. Vaid. So you joined CHRIAS in 2015, and prior to that, you were in PA, right?
Yes. So I did my medical school from New Delhi, India. I did a part of my surgical training in New Delhi as well. From there, I moved to England, and I was there for 3 years, where I furthered my surgical training. And around that time, there was a robotic revolution happening across the Atlantic, meaning in the United States. And I was really interested in pursuing that and taking care of the patients with colon cancer with the advanced technology. And for that, I crossed the Atlantic Ocean and came over to the United States and did my surgical training and also fellowship in colorectal surgery.
Great. So well, we've known each other since 2015, and we spent a lot of time together. So it's great to have someone clinically so strong on our team. So we are always happy to have you. So now, when we discuss bariatric, the issue is a little bit different, but when it comes to the colonoscopy, there's always this little smile on everyone's face first. Because there's the fear of colonoscopy. But today, it's not just the colonoscopy, but also the colorectal part of our business that we are going to discuss. So if you can actually give us the brief background on what you do, and I have some specific questions on COVID-19, related to COVID-19, and we'll go from there.
Of course. So, as I'm a colorectal surgeon, I would say more than 95% of my practice is related with the diseases of the colon and rectum. I have a lot of my time and practice part which goes towards taking care of patients with colon and rectal cancers. That includes diagnosing them. We are doing colonoscopies or doing screening colonoscopies for that matter. Then, of course, we spend a lot of time discussing them in the tumor board or the multidisciplinary clinic, for which we actually work very closely with Helen Graham Cancer Center. And from there, of course, I mean, if they need surgery, then I am involved in taking care of them in doing their surgery, be it robotically, laparoscopically, or open. So that's one part of my practice. Second part involves benign colon and rectal cases, which means diverticulitis, Crohn's disease, and ulcerative colitis, to name a few. I also take care of a lot of anorectal cases. Most of them, we take care of them in the hospital, in the office, like treatment of hemorrhoids, fissures, and things like that. And sometimes, of course, we have to do surgery for those reasons. I mean, if their conditions are bad, then of course we take care of them for that also. And also I do a lot of screening colonoscopies, which is part of my taking care of patients with colon cancer. Kemal, if you can go back a page on this slide, I would like to, if you can start from the beginning, please, if you don't mind. Thank you. So this is a good slide which I made to kind of talk about colon and rectal cancer. And it's a very brief slide so that it won't bore a lot of people. But a few kind of highlights about this is that colorectal cancer is the most common malignancy of the GI tract. In the United States, colorectal cancer is the third most common cancer and second most common cause of cancer death overall. That's why we're talking about this. That's why we're talking about to diagnose it early, and also for us to be able to treat it in a more efficient fashion. The lifetime risk in the Western civilization is about 6%. And the good news is that the colon and rectal cancer is decreasing in both in the incidence and mortality in the United States, whereas elsewhere it's increasing, which is not a good news, bad news for them, but for the United States, that the incidence and mortality is both decreasing. And mainly this is attributable because of efficient screening protocols which we have in place. And we will talk about that, but mainly colonoscopy is is the gold standard for screening of colorectal cancer. We can go on to the next one, Kemal, if you don't mind. So in this graph, we're talking about what is the age distribution of colorectal cancer. And as you can see, mainly it is a disease after the age of 50. And that's why, according to the old protocol by American Cancer Society and the United States Cancer Prevention Task Force, the recommended screening time for colonoscopy used to be 50 years. And I'll show you in a second why that has changed in the subsequent graphs. If you can go further, please.
This one too. So
no, I think it is important that we are taking our time to kind of discuss why it changed, because this is really important. That normally we do screening at the age, we used to do screening at the age of 50, but now it has come down to the age of 45. So if you look at the left upper graph, ages 20 to 49, you can see that both the incidence and the mortality for colorectal cancer is actually going up in the United States. Whereas if you look at the other two graphs, 50 to 64 and above 65, everything is coming down. So that was the reason why the American Cancer Society, Society of Colorectal Surgery, GI societies, and also now the US Cancer Screening Task Force has decreased the rate of screening at the age of 45. Now, oftentimes I get asked a question, what happened? Why are people, younger people, getting more and more cancer? So if you look at this graph, everything changed around 2000. And it's unclear if it was diet related or diet high in red meat, less exercise, more sedentary lifestyle. Unsure what caused it, but certainly something happened around the 1980s to 90s, I would say, which led to this change. We can go on to the next graph if you would like. And so what causes colon cancer? I mean, what are the risks, factors which leads for someone to get this colon cancer? So, of course, genetics is one, but we cannot change that, okay? I mean, our family history is something which we cannot change, but what we can change are the behavioral factors. And if you look at it, I've marked it with a wide arrow. It's the alcohol, obesity. I mean, we are in the midst of an obesity crisis in the United States. Diet high in red meat. I cannot overemphasize this fact. Low fiber and more meat is one of the reasons why we are seeing more and more diverticulitis and colon cancer in the Western population. Along with that, not moving, like having more of a sedentary lifestyle, because we are in, this is a developed country, we are doing less and less physical exertion. That certainly is causing the risk factor for colon and other diseases to go up, essentially. Yeah. Well, in this slide, I mean, this is if someone wants to know what kind of genes are involved. So, I mean, every cell in our body is designed to live, grow, and die. And this is controlled by our DNA. So like the hair cells, like the skin cells, they go through this cycle of 30 days, 40 days, however long it might be, that we're going to have shedding and the new cells are going to come up. That's how our body takes care of itself. Certain cells lose the power of death. They want to live. So when that happens, it basically happens at the level of the DNA as switch is flipped. It may be at the level of the chromosome, DNA, whatever level, but it happens and the DNA gets flipped, and that's why those cells grow, don't want to die, and turn into a polyp, which then leads to a cancer. This is just the cancer stage by survival. This is a very important chart, but if you can see that if we catch colon or rectal cancer at an early stage, 5-year survival, you can see, is close to 90% here. Actually, in this, they have both stage 1 and stage 2. Stage 1, we are talking about more than 92 to 95% survival, which is a great survival. Stage 2, we are talking about 80 to 90% survival, again, a great survival. But once we get down to when the lymph nodes start getting involved, or we have spread to the lungs or liver from colon cancer, that's where the survival and the prognosis goes down. So it is highly important that we catch it. First of all, we don't want it. We want to prevent it. But if we have it, we want to catch it at an early stage so that we are able to target therapy and basically improve our survival.
So, Dr. Vaid, now you are, what I'm hearing from you is the way that we are actually, if we are able to get this earlier, diagnose this earlier, then it's helpful and it's great. So now, again, I'm speaking from someone, what am I now, 46, 47, I guess, like whatever my age is. There's, I mean, yeah, we were maybe earlier, we were kind of like maybe smiling, or maybe some people are finding this kind of like embarrassing in some ways. But in what situations patients should be concerned? Like if, like there's the hemorrhoid part of this, right? So that's related to this whole issue. And some people, and because I'm in the medical field and I hear, like, even though I'm not a clinician, many of my friends, they come to me with these questions, and some of them, they just simply say they don't feel comfortable going to a doctor's office when they have rectal bleeding. So what are, like, is every rectal bleeding like severe, could be severe? Like what is that, if we need to be scared of this, we should. So what do you suggest from that point?
Yes, it's a very good question, actually. Look, it's human to have hemorrhoids, okay? Every human being has hemorrhoids because they are just the dilated veins in the lower part of our body. And every bleeding can be attributed to hemorrhoids because bleeding can happen from hemorrhoids, but it can also happen from other sources. Mm-hmm. So whenever anyone has bleeding, okay, I'm going to make it very blanket. I'm not going to get into the nitty-gritties of what color, painful, painless, because then it's going to get very confusing. If someone has rectal bleeding, I think he should be evaluated by a doctor, preferably a colorectal surgeon, because that person or that colorectal surgeon can not only evaluate their hemorrhoids, but also would be the best person to look at their colon and see how to handle those hemorrhoids if everything else is normal. And for the most part, I don't want to scare people, for the most part, rectal bleeding would be hemorrhoidal in nature. But having said that, we cannot say that every bleeding is hemorrhoidal. So that needs to be evaluated. Like, how are the hemorrhoids? What are the symptoms like? And that's how you can proceed with that.
And that risk of age, actually, as the age is going up, like, Tanner and George, these guys, they're like in their 20s. So they may have the issues because maybe they're working out too much, they're lifting heavy weights. But then when that age is going up, then like at my age, if I have that problem, I should call you, right?
Well, Kemal, everyone, even the guy who's 20 or 25 or 30, if they're having bleeding, that needs to be evaluated, okay? Mm-hmm. We just talked about the graph which we showed, that the incidence and mortality of rectal cancer, colon cancer is going up in people less than 50. And I got to tell you, I'm not proud of that, but I have seen people in their 30s with rectal cancer. I just had a patient, she was young and she had rectal cancer. Now, I have operated on people 36, 38 years old with rectal cancer. Now, those cancers did not start at the age of 36. It takes a normal polyp to turn into cancer, takes about 7 to 10 years.
I see.
So, these polyps started at like 7 to 10 years before they turned into cancer. So, any symptom should be evaluated. And the commonest symptom which someone can have from colorectal cancer would be altered bowel habits or abdominal pain.
Mm-hmm.
I just don't feel right is one of the common symptoms people say. I feel heaviness and bloating. That's another symptom people say. Anything, any change in your bowel habits, I think should prompt a discussion with at least your primary care doctor, if not a colorectal surgeon.
Sure. Now, I have some specific questions with COVID-19. Now, as you know from United Medical ACO side, colorectal cancer screening is one of our quality metrics for most of the insurances. And in many cases, we have some difficulties with some patients. But with the COVID pandemic, this became even more problematic. So, like point blank, should I postpone routine cancer screenings because of coronavirus disease?
All right. So let me give you some numbers here. In 2020 in the United States, it's estimated that we're going to have 150,000 cases of colorectal cancers. Okay? Mm-hmm. This is from the Cancer Society website. Is cancer gonna sleep because we have coronavirus? No, that's not gonna happen. What's gonna happen is, if we don't screen these people now, if they have a polyp, that polyp is gonna get bigger and may turn into cancer. Or that polyp may get to a point that we may not be able to remove it endoscopically. Not all polyps are cancer. And the good thing about colonoscopy is that not only we diagnose it, we also remove it, unlike other tests. So that's why it's highly important that we don't let colon disease or colon cancer disease be a collateral damage from coronavirus. Coronavirus is a problem. It's a big problem, of course, and it's going to stay with us probably till the end of next year, unless we have some turnaround. But we cannot have other conditions. We cannot have coronavirus lead a negative impact on colorectal diseases, so to speak. So I would say, of course, if you have symptoms, it is highly important that we proceed with your examination. If not, we still should be doing our routine screenings, but with all the, precautions we take.
So in those cases, in the past, I remember if it was a straightforward screening, we would schedule them directly at the surgery center. Now, perhaps those patients can do a video call telemedicine with you because they may have symptoms that they don't know, right?
Of course. So people who need direct scheduling, meaning that they have no symptoms, they can be scheduled at the hospital, at the surgery center, depending on where our availability is and depending on what COVID precautions need to be taken, of course. So, if some symptoms, not everyone needs to be seen in the office. We have a very vibrant telemed population of people I see, and we have adequate resources and we can totally do that.
So the other thing is you are still, of course, seeing patients in the office in person. Now, because our practice is multi-specialty surgical practice on the bariatric side, and we also have 3 different locations. So we are spreading out the patients, doing a lot of them on telemedicine, and then patient has to be seen. We are bringing them in the office. So if we can maybe discuss that a little bit so that patients know, especially if they have symptoms. Now the screening, fine, we can do the telemedicine and other stuff. But if there are symptoms, you are seeing patients in the office and then we make those adjustments. Can you kind of tell us those adjustments that we made?
Of course. So if someone has symptoms, meaning if someone has rectal bleeding, if someone has some lesion he or she has noticed around their bottom, or if there is some infection or abscess, they of course then need to be seen in the office, not just for me to diagnose them, but to actually treat them. Because if they have hemorrhoids, I can remove them in the office. If they have an abscess, I can drain that abscess in the office. If their hemorrhoids are bleeding, I can do a thing called rubber banding in the office. Mm-hmm. So those are treatments which we need to be able to offer patients. So yes, for those particular reasons, not only to diagnose, but also to actually manage them, we need to see them.
Number two is the patient who's had surgery and now is having some issues from that, maybe, which is a minority of our population, luckily for us. Or if they have a drain which needs to be removed, or a bridge from their ostomy which needs to be removed, or clips to be removed, yes, then they will need to be seen in the office for those reasons. But if there's a normal post-operative patient, if he or she is doing fine, we can totally do a telemed for them. And same holds true for post-anorectal cases, anorectal surgery cases. If they are doing fine, they have no symptoms, everything is great, they can do a tele. But if something needs to be examined, then of course they will need to come to the office for that reason. So what we've done in our office is we are not doing any double booking, of course, because we want minimum people in the waiting room, so that there is no cross-contamination. We are cleaning all the rooms after every patient so that, all the surfaces are hygienic and we are COVID-free. Everyone's wearing masks, and take our time to examine our patients, see our patients, and as much as possible, we are trying to advocate for telemedicine.
Sure, and I do also want to remind our patients again, especially now, it was same before, but one of the most important elements for us now is patient portal. So telemedicine and other portal related things, you can do all those through your portal. When you call our office, just like any other medical offices, we have limited number of people who are answering the phone. So if you are calling us for your upcoming appointments, canceling your appointments, lab results, anything that's available on your chart is available on your patient portal, which also is the main driver for our video visits, telemedicine through patient portal. So we cannot emphasize this enough. Please, our patients from CHRIAS, from United Medical ACO, make sure you activate your portal and take in charge of your own records, because this is the access is everything these days. So I do want to just remind that as like my routine reminders. So Dr. Vaid, the way that this discussion was happening, and then I know we had some technical difficulties, but what I realize is that it's almost we have to kind of separate and divide these into a couple different sections, and maybe have those specifically discuss just the screening and just the cancer piece in different sessions. And I do hope that we can actually schedule some more live sessions, and then we can make those available for our patients. Now, anything before we close, any closing comments you have?
Yes, so no, I think I absolutely agree with you. Yes, we should have more sessions, and so I mean, more education we have for our patients is always better. Well, the year's coming to end, and hopefully the COVID also with the vaccination and other measures hopefully should go away, or should be something which we can control. But we should not ignore the symptoms we are having, and we should not have our health have a collateral damage from the reasons for COVID, basically speaking.
When you said, when you mentioned the time again, so it just reminded me of this other issue. There is a big hesitation on the COVID vaccine. And I asked many of our providers, and we are putting a video together. It will be available tomorrow. But I was gonna ask you, what's your position on COVID vaccine? Are you going to get it? When you are going to get it? And what do you tell the patients what they should do?
Yes, so COVID vaccine. I am scheduled to get my COVID vaccine tomorrow. Let me just start off with that, so that we're not being skeptical about it. Mm-hmm. So it's a new vaccine, of course, but it has gone through the trials and the research. Although we did not have 4 years to do that, it was expedited. But we do have enough data and enough report to kind of know that it is a safe vaccine. Of course, I mean, what's going to happen in 5 years? We don't know that. Okay, no one knows that. But we know that if someone gets coronavirus, they can die. That we know. That's a fact. So, and it's not only like elderly people are dying or people with conditions are dying. I mean, we are seeing regular healthy people, physicians, non-physicians, who are dying from coronavirus. You don't want to be a statistic to say that he was 40. I'm 42 years old. That he was 42. He got corona and he had a heart problem or whatever. I don't want that. So I know that coronavirus is going to be with us at least till the end of 2021 or 2022. If I chose to say today that I would not take the coronavirus vaccine because, I don't have enough data or whatever reason I may come up with, which is contradictory because we do have enough data, then am I not going to be taking it till the next 6 months or 1 year? Well, eventually I will either get coronavirus or I will have to do something which is going to hopefully protect me from coronavirus.
Absolutely.
So my stand is, and the long term, what's going to happen in 5 years? Well, then you got to wait for 5 years, and then we can find out.
At least we'll be alive in 5 years, right? So the issue is if we are not alive, because then what's the point of 5 years from now?
Absolutely. Good luck not having corona. Exactly.
Yeah. So I think people they have maybe some right reasons from the prior vaccines. We understand that, but this is a public health emergency. It's not just your own health, but for everyone else's health. So, when I talked to the physicians, I felt even more comfortable. In the beginning, maybe I was kind of hesitating, but after talking to you and other physicians, then I understand that it's my obligation to the society that I have to be vaccinated when it's available to me. So that's our position from United Medical ACO standpoint. But our video will come out tomorrow, and we'll share that with our patients as well. So hopefully, it can make some impact on people's understanding. Well, Dr. Vaid, I know I took some time from your office hours today, and I do appreciate that. And then we'll do more sessions together. And next week, we have an event on Friday at 3 p.m. on the bariatric side. But for the new year in 2021, we'll come back with more colonoscopy and colorectal related items. Again, thank you so much, and we'll see you soon. Bye-bye.
Perfect. Thanks, Kemal, and happy